Good morning, everyone, and thank you very much for the invitation. So, I've been tasked with talking about biologicals in the management of uveitis. And you would know that so the place of biologics in management of uveitis comes as more or less of a last resort. You use glucocorticoids, you use conventional steroid sparing agents, and then finally, if you can't still control the disease or you can't take the steroids off, you opt for a biologic or sometimes targeted synthetic therapies. And why is it a last resort? Why is it more effective? Is because it's very specific and it targets downstream targets in the immune response. For example, if you take mycophenolate, that inhibits T cell and B cell proliferation by inhibiting purine synthesis. So essentially, if you look at the inflammatory cascade, you'll be targeting something much more upstream. You will be getting rid of the bad guys, but at the same time, you could be targeting your regulatory T cells. So there'll be off-target adverse effects. Whereas biologics, mainly monoclonals, will be targeting specific points, and therefore they will be technically more effective, and also the safety profile would also be better. So there are many biologics in use, not just for inflammatory diseases, for certain cancers, for osteoporosis, so many things. And I'll be talking about biologics which are commonly used for uveitis, look a little bit at the adverse effects because it's important for us to monitor these patients, and talk a little bit about special populations, particularly looking at pregnancy and the other therapies that are sort of being investigated, other biological therapies and targeted synthetic DMARDs, and a little bit about cost and availability of these because it's very important in our context. So when we look at biologicals that have been used for non-infective uveitis, we have the monoclonal antibodies, and the main ones that are being used are the TNF inhibitors. Then we have others like anti-CD20 antibodies, rituximab, IL-6 inhibitors, tocilizumab, and a lot of the others that we use for psoriasis, like secukinumab and ustekinumab. And then other recombinant interferons, interferon alpha and beta, have also been used. Sometimes intravenous immunoglobulins, the human normal immunoglobulins have been used. And then finally, the targeted synthetic DMARDs, those are the JAK inhibitors, which are small molecules, synthetic molecules that are available as oral tablets, are also being tried out for uveitis. But if we take a look at the ones that are licensed for use, it's primarily adalimumab, which has been licensed in 2016, and after that, its biosimilars are now coming up. Imralid has been licensed in 2018, but we do use it interchangeably with the other biosimilars because it has been proven to have the same efficacy and safety profiles. And all the others that are being used are off-label. So when we look at TNF inhibitors, we primarily have 5. So that's adalimumab, infliximab, golimumab, certezumab, and etanercept. Of these, infliximab is only available intravenously, so they're given as infusions. The others we can give subcutaneously, and in other countries, these are just auto-injectable pens that we send to the patients and they get it at home. But here we do need them to come into hospital, and we have our day infusion centers that run where they come in and get the shot and go off. So the differences between these TNF inhibitors are both in terms of their structure and also their pharmacokinetics, and a little bit on the pharmacodynamics as well. So if we look at infliximab, it is a chimeric monoclonal antibody. It means that there is a part that's human and also part that's partly murine. And because of that, the antigenicity of infliximab is much more than what we would get in a fully humanized monoclonal antibody. So that's mainly adalimumab and golimumab. And etanercept is not a full antibody in itself, it's a fusion protein where we get the Fc portion that's bound to this extracellular domain of the TNF receptor. And certolizumab is a much smaller molecule because it has the Fab segment which is bound to a polyethylene glycol molecules. And because it's much smaller, it has a better tissue penetration and it is also less immunogenic than particularly than infliximab. And there are also subtle differences in the way that these act as well and where they bind. For example, etanercept binds to both TNF alpha and beta, and etanercept does not cause an apoptosis of the TNF bound cells, whereas the others do. And of these 4 non-infective uveitis, the main ones that are used, where the largest body of evidence is adalimumab and infliximab. And in terms of evidence, adalimumab, there's a whole heap of evidence from randomized control trials and then going on to meta-analysis that shows that it is very effective in inducing remission in uveitis. So this is from an extension of a phase 3 clinical trial called Visual 3, that was one of the main trials for adalimumab in uveitis, that shows that vast majority after starting adalimumab go into quiescent, and the ones on steroids are very, very less. And also it has a very good steroid sparing effect long term. And the same can be seen with infliximab. About 95% achieve quiescence when you start infliximab. But then what about the other TNF inhibitors? So golimumab, again, there is some evidence that it is effective in controlling inflammation and also as a steroid sparing agent. Certolizumab, again, these are not large trials, mainly observational studies, that also shows that it's potentially a good alternative if you can't use anything else to control inflammation and to reduce the steroid load. But etanercept, on the other hand, has been paradoxically associated with uveitis, and it has been shown to have no effect. There's one randomized control trial that has been done, small number, but still it has been found to have no effect. And why? It has been postulated that it's because of these pharmacokinetic and dynamic differences. For example, etanercept has a shorter half-life, its volume of distribution is smaller and it clears faster, and also there are 2 types of TNF receptors. When it comes to etanercept, it leaves the TNF receptor 2 pathway at least partially open, and it doesn't cause a lysis of TNF bound cells. So etanercept is not an option for uveitis. So when it comes to TNF inhibitors and adverse effects, the commonest things that we see are the injection site reactions, and with infliximab, infusion reactions. So we can get immediate infusion reactions, so mainly sort of hypersensitivity reactions and sometimes changes in blood pressure, etc. Or else we can get delayed reactions for infliximab. So those are generally between 1 week to 2 weeks later, we get sort of a serum sickness, sort of an illness. Other things like neutropenia are very rare. Other cell lines are hardly ever affected. With demyelinating disease, if there is a diagnosis of a demyelinating disease, we'd be very, very cautious and often avoid TNF inhibitors. It has been associated with demyelinating diseases like multiple sclerosis. Heart failure, there is some association, and the point is that if there is heart failure of class 3 or 4, we'd either avoid it or be quite cautious. There's a risk of malignancy that has been associated primarily hematological malignancies and non-melanoma skin tumors, and infections. This is the most important thing in our context, I would say. So there is an increased risk of bacterial infections, zoster, and particularly tuberculosis with TNF inhibitors, because tumor necrosis factor is needed for granuloma formation to get the immune cells and to keep the granuloma going. So because of that, we see an increased risk of TB, reactivation or new infection with TNF inhibitors, and it's more with the full monoclonals, with adalimumab and with infliximab as well. But it's quite sort of, the risk is less with things like certolizumab. So what do? We need to screen them before starting treatment. And we need to screen for other latent infections, including hepatitis B and hepatitis C. We often make the mistake of just doing a hepatitis B S antigen and an antibody. But you need to remember, if they have seroconverted, they might not have the hepatitis B antigen, might be positive for hepatitis B S antibody, which could be due to vaccination as well, but they'll always be positive for anti-core antibody. So we need to do the anti-core antibody as well in all these patients. And we screen for latent tuberculosis and for HIV as well. Another problem with TNF inhibitors is treatment failure. In some of the studies, it's as high as 40%. And one of the main reasons for treatment failure is anti-drug antibodies that are formed against these TNF inhibitors. So when you get anti-drug antibodies, you can get infusion reactions, it could be local or systemic immune reactions, and also there's treatment failure. And it has been shown that using other conventional DMARDs, particularly methotrexate, you don't need to give a lot, just a small dose, can reduce the formation of these anti-drug antibodies. And the other problem is that it has a potential to induce autoimmunity by itself. So we can get a drug-induced, particularly lupus, with TNF inhibitors. So another main consideration which we often forget is immunization, preferably prior to starting therapy. If not, still we need to think about it, keep it in our mind, particularly pneumococcus and seasonal influenza vaccines, and it can be given even after starting therapy, depending on the regime that we're using. Coming on to pregnancy, we are very, very scared to start or even continue any sort of DMARD. But the thing with monoclonals, biologics, is that initially in the first trimester, it's primarily a diffusion that happens. And later on, it is the uptake of these antibodies into the fetus is mediated by receptors that are expressed in the placenta, and they're endocytosed and then put into the fetal circulation. So towards second and third trimester, the fetal level of antibodies go up. And the primary concern is either infections or giving live vaccines to the fetus. Otherwise, there's not a great deal of evidence of teratogenicity. There is some evidence about sort of intrauterine growth retardation, etc. But so TNF inhibitors are considered safe in pregnancy. The only thing is we need to watch out for live vaccination afterwards, but it's one of the DMARDs that we can continue in pregnancy. Other therapies, as I told you, tocilizumab, secukinumab, anakinra, rituximab have been used. Not a lot of evidence, but we know that this is a heterogeneous disease, so these can also work. So other things like, as I told you, JAK inhibitors are coming in. Certain antibodies have been tried at intravitreal treatments as well. Cost and availability, now these are costly, costing more than 1 million rupees per person per year. And if you look at the total consumption cost, they cost quite a lot. They consume quite a lot of the annual consumption budget. But these can still be cost effective. They're costly, but can be cost effective. And why do we need them to be cost effective is because we have been spending much, much more than we can over the years. So it's important for us as professionals to have contextual guidelines and commissioning criteria and monitor these use. So thank you.